Hi, dear friends. This is Dr. Simanchal Goel. So, coming to a very interesting case, this is a diabetic patient. We have controlled his diabetes for the past 15 days. He's on insulin, and we have taken this case up. So, you must remember that diabetic metabolism is not normal. These cells, these tissues, these patients use a lot of alternate pathways to just grab nutrition, and one of them is sorbitol pathway, which causes these cataracts to develop in a particular fashion. All the age-related cataracts, you must be knowing that they develop nuclear sclerosis first, and then there are cortical components. But these cases have a slight change in that they have cortical and nuclear components, but they are sticky, they are gooey in nature, they don't chop that well. So as soon as I put the speculum in the patient's eye, my OT assistant tells me whether the patient is diabetic or not. I change my strategy. If I know the patient is diabetic, I switch the strategy to flip and chop, not direct chop. Please mark my words, you're going to thank me later and develop this strategy from your early days to always go for a flip and chop in diabetic patients and not for direct chop. Direct chop works beautifully in age related cataract that are 90% of your workload. But as this diabetic pandemic increases in the whole world, you need to know alternate strategies to develop and operate these cases as safely as you can. So for flip and chop, as you know, you should do a good hydrodissection so that one pole of the nucleus prolapses out of the bag. For me, it is always the left pole because I am a little right-handed surgeon. It is better. It is easy for me to just pick the left pole of the nucleus with my phaco, and I'm putting some more visco to protect the endothelium right now. And for phaco, high vacuum is the most important prerequisite in this case. You switch on your continuous mode and you elevate the bottle height to around 90 centimeters, and you put your vacuum to around 420 to 430 millimeters of mercury, and you just aspirate the one pole of the nucleus. And because the continuous mode is on, the nucleus is going to the cortex and the nucleus is going to melt in front of your phacotip. And just like that, we need not to impale the nucleus first and then chop the nucleus first. In those cases, in because these cataracts are soft, you can easily cheese wire the nucleus and hit the posterior capsule, and eventually leading to a lens drop. I've noticed these diabetic patients don't dilate well either. So in those cases also, prolapsing one pole out of the bag and causing a temporary fixation of the pupillary size is a very easy technique, because once the pupil is small in diabetic patients, it's always risky to impale the belly of the nucleus and going for a direct chop. In those cases also, the nucleus does not chop well and there is a risk of PCR. So this is a very interesting fun case. You should go back to the video, replay it a couple of times, and notice what I have done. Simple case, 6 to 7 minutes of operative time. The patient was really happy. The patient was screened for NPDR earlier and he got a very good vision regardless. So as the diabetic cases in your career in India, in US and all across the globe increase, we as cataract surgeons must know alternate techniques of operating a cataract case. A good surgeon, a versatile surgeon, is the one who can switch his techniques according to a case. If it's pseudoexfoliation syndrome, you should know the go-to technique. If it's a zonular dehiscence case, you should know the go-to technique. If it's a small pupil case, you should know the go-to technique. If it's a diabetic cataract, the technique changes. If it's age-related cataract, the technique changes. If it's brown, hard cataract Niagara case, the technique changes. If it's any other case, your technique should change. If the patient has high astigmatism, the technique should change. If it's a toric case, your technique changes. If it's a multifocal toric IUL, the technique changes. So all these cases I'm going to discuss in the next video. I'm going to give you my notes from my post-graduation days. So you better watch out for my videos and kindly push that subscribe button if in case you don't have right now. That's all from my side. I hope you like my videos. I'm just going to put a monofocal IUL in this case. The bag is empty. I have done the cortical aspiration. And as you can see, the side ports and the main port right now are clearly visible and in the T-shape orientation, because the patient had minimal degrees of meiosis, that is, the pupil was not dilating properly. I have taken the side ports and the main ports 1 to 2 mm anterior to the limbus. That way you will have minimal chances of iris prolapse also. Small pupil cases are infamous for iris prolapse, and once the iris prolapses, the whole case gets really complicated and risky. So that is a beautiful IUL with a beautiful glow and minimal inflammation. You cannot give these patients oral steroids, mind you, because they increase the blood sugar levels, but you can give them topical dexamethasone. My go-to drug in the post-op period is a combination of moxifloxacin and dexamethasone. And never forget Amplinac or Nepafinac, Nevanac in these patients, because there is a slight chance of Irwin gas syndrome also. So once ever in your career, if the patient comes up with a brilliant post-op day 1 result of 6/6 and the vision deteriorates in coming weeks, you better get an OCT for Irwin gas syndrome. And once Irwin gas syndrome sets in, the drug of choice is first the cocktail of drugs of difluprednate and Nepafinac. You put the patient on strong steroids, topical steroids, for around 1 month and see with a repeat OCT. I have found a very high success rate with topical high dose steroids. And that's all from my side. I hope you like my videos. This is Dr. Simanchal Goel signing off. Thank you so much.